Good morning. I think we've just started. I've had a strange voice telling me we've begun, so we must have done. Welcome to a joint event being organised between the Mental Health and Smoking Partnership and Equally Well UK. My name is Andy Bell, and I work at Centre for Mental Health. We're one of the organisations that hosts the Equally Well Collaborative, supporting physical health for people living with a mental illness. And we're really delighted today to be working with the partnership, which of course is hosted by ASH, our wonderful friends at ASH, to talk about an incredibly important issue, perhaps one of the most important issues when it comes to equal physical health for people living with a mental illness. I'm really pleased today we've got an outstanding group of speakers for you. I'm really looking forward to hearing from them, and the whole idea of this webinar is, first of all, we hear some really good content about some research that's published just today, and secondly, that we have a really good debate with you. And I can see it's 124 people on this, so that's fantastic. And so we'll want to hear from you as well. So I think the first thing we have to do is first of all, thank Ash for organising this, and John and Hazel and team, thank you for arranging this and making this event possible. Really grateful for the effort that's gone into that, and for getting this group of people together. The second, and I think we've got some wee slides to share with you just to give you some of the housekeeping before I shut up and let the speakers do the really good stuff. So here's what you got to look forward to. I'll introduce each speaker very briefly before they talk, but I won't do the whole bio. I'm sure people don't need that. But a fantastic group of people who have got time to talk later. If we can move on to the next slide, please. I feel like I sound like someone at one of those awful government press conferences when I say this. Yeah, next, please. So just to tell you that this session is being recorded. If you don't want your face to appear, I don't think you probably need to, but just to be aware that the speakers will be recording, or will be recording what the speakers say and the questions that come up. The slides, you don't need to worry about photographing or writing notes, because they'll be circulated afterwards. If you're having any technical problems, if you can use the chat function, let the organisers know there and they'll sort it out. And there's an email address if you get completely chucked out. So do take notice of that. It's admin@smokefreeaction.org.uk with any technical issues. And then the last slide, which will be relieved to know, so that you won't have to hear from me anymore, is really just to say that we're looking for questions at any time during this webinar. So you might think of a question while the speaker is speaking. Please use the question bar, which seems like a perfectly reasonable proposition, doesn't it? Which is on the right-hand side of your screen. We may not get time to answer all the questions on the webinar, and the organisers have rather generously said that if they don't get answered during the session, someone will circulate an answer afterwards, which I've never known before. So good for you guys. And that's pretty much it, I think, by way of welcome. And that just means that I need to ask Lucy Furby to speak. Lucy is a public health registrar working at Action on Smoking and Health, and has led this research. So Lucy, over to you.
Thank you. Can everyone hear me?
Yes.
Can people hear me? Great, thank you. My name's Lucy. I'm a public health registrar, and I'm going to be presenting you today the key findings of the report that has just been published on training needs of mental health nurses and psychiatrists. I'm just going to leave this quote here for a couple of minutes, because it really does tell us about what I found to be a common mindset between the people I spoke to regarding smoking and mental health. This is from a psychiatrist who reflected after we spoke in the focus group about how he perceived the role of smoking and people with mental health problems or illnesses. We'll get back to culture of attitudes and beliefs a bit later, but it's important because it kind of sets the scene about how we feel about the role of training. The good news is that there's increasing emphasis to focus on smoking and mental health, and developments in policy reflect this. There is a commitment that in the long-term plan that a smoking cessation offer will be available as part of specialist mental health services for long-term users of specialist mental health. And on the advice of PHE, this will include an option to switch to e-cigarettes while in inpatient settings. We do know that certain training interventions can improve performance of smoking-related tasks and improve reductions in smoking prevalence. We also know that mental health service users are more likely to respond positively to smoking cessation support when it's delivered by a mental health professional compared with other health professionals. But we also know that progress has been slow around training staff. There was a report that ASH published called A Change in the Air, and this identified unmet training needs as a specific threat to maintaining the momentum of reducing smoking prevalence among this population. The report aims are quite simple in that they want to identify the areas for improvement in training for mental health professionals in relation to smoking and make relevant targeted recommendations based on survey and focus group data. Due to time and capacity, it focuses on psychiatrists and mental health nurses currently practicing community or inpatient and adult mental health settings. But we do acknowledge that there are many other workforce groups that play important roles in smoking cessation support for people with mental health conditions. And reviewing their role and training is an important area for future focus. So these are the headline findings. The report actually itself is quite long, and there is a lovely exec summary that summarises the findings. But the headline findings are that, encouragingly, staff are well informed about the health impact of smoking, but there is a definite lack of knowledge on key aspects. A lot of this is about how smoking particularly relates to mental health. Also about the role of medications, about delivery of very brief advice and all the other cessation options available to people who smoke. We also found that training on smoking is limited or sadly in some cases non-existent across people's education and working life. Importantly, we found that there are enduring myths and negative attitudes about addressing smoking, and some of these are linked to how people feel about smoke-free policies, and we'll get onto this a bit later. And plus, on top of this, there are additional organisational barriers to effectively addressing patients smoking outside of these training barriers. Encouragingly, there is an absolute high level of interest in additional training, and there is really a great level of support for embedding training in both academic training and in the workplace. So the overarching recommendations, these are the main recommendations on the headline findings. And we actually developed a set of 17 recommendations, but the first two here are related to the overall findings, and they can be viewed as those that are kind of really the overarching important ones, that a plan must be developed and implemented by NHS England to ensure training needs meet the requirements of implementing NICE guidance, and that's in both inpatient and community mental health settings. And as we roll out the NHS long-term plan commitments, gaps in training must be addressed in line with the detailed findings in this report. So the report itself is split into different sections that look at current training, existing knowledge and skills, staff attitudes and beliefs, organisation barriers, and addressing the gaps. As I said before, it's quite detailed, but there is a great exec summary available. So regarding current training, we know that training programmes for healthcare professionals improve the delivery of smoking cessation interventions and lead to reductions in smoking prevalence. We also know that a lack of training during undergraduate and postgraduate education or within the workplace leaves staff ill-equipped to implement smoking cessation strategies. This slide, and there was a lot of data to choose from, so I couldn't show all the graphs, but this slide shows the proportion of respondents that did not have or could not remember having any training on various smoking cessation support interventions. And the one we're particularly interested in, I guess, is the first one about giving very brief advice, and also maybe the later ones. I mean, we don't expect mental health professionals to be experts in giving behavioural support for smoking cessation, but if you look at very brief advice, nearly a fifth of mental health nurses reported that they never had or couldn't remember having training in delivering very brief advice. And as we know, the role of e-cigarettes is quite important. Over half of mental health nurses couldn't remember having or not having any training in using e-cigarettes as an intervention. This is the findings for the psychiatrists, which reflects that far larger proportion of psychiatrists couldn't remember having or didn't have any training in the same intervention. So over a third of psychiatrists can't remember or didn't have any training or giving very brief advice, and a 76% didn't know about the use of e-cigarettes in the mental health care setting. And if you see the other smoking cessation medications, phenytoin, etc., and the use of nicotine replacement, that's almost over half of psychiatrists hadn't received training or couldn't remember receiving training on these, which is unfortunate because they play an important role in smoking cessation support. Other findings in current training included that training experience varied a great deal between professionals, and this suggests a lack of consistency in undergraduate, postgraduate and workplace training. And while the majority of staff report inadequate training in all three settings, gaps in training were reported far more frequently by community-based staff than inpatient staff. And despite relevant competencies in current curriculums, only 17% of mental health nurses and 13% of psychiatrists surveyed felt that their undergraduate training on the links between smoking and mental health had been adequate. Relevant training experiences were also found to occur more frequently in workplaces than in undergraduate and postgraduate settings, although large numbers of professionals still reported gaps in training in relation to key aspects of national guidance. It's encouraging that there was a clear appetite for more training to address smoking with people with a mental health problem. It was also felt that training should be compulsory in academic studies, but also that it should include real life stories, be tailored to different settings, especially community settings, that it should be repeated at different points during a career, and that it really should be related to mental health and not just physical health. Typical barriers included being unaware of what was available, lack of time, workload being too high was one that was repeated often, and training not being provided at the workplace. The recommendations are quite wordy, so I might not go into these in detail because they are in the exec summary, but the recommendations around current training are just that we would ask the standard setting institution that they really ensure that they're supporting institutions to include appropriate content on smoking in their curricula, and that organisations such as Health Education England and NHS England really do need to ensure that there's some kind of formats that NHS trusts can use for staff education and training purposes, and that these are regularly updated as we find out more about things like the use of e-cigarettes, for example. And lastly, that future training plans really need to be provided for community as well as inpatient mental health settings. It was felt that training was often more focused towards inpatient mental health staff to the exclusion of community staff. Existing knowledge and skills, there was an apparent lack of understanding about what actually constitute very brief advice. So whilst there were high levels of reported confidence and knowledge on smoking and mental health topics, these were inconsistent with the low confidence and lack of knowledge that the kind of focus groups demonstrated. In particular, it seemed that a lot of staff weren't fully aware how to deliver each component of very brief advice, even though it's something that they say they do regularly. Because we asked if they were confident in delivering VBA as an intervention, but we also asked about each component: the ask, the advise, and the act. So whilst people had high confidence in asking and advising, there was kind of a lower confidence in actually delivering the act stage. With regards to clinical skills, knowledge and training, there was a notable lack of knowledge among staff on stop smoking medications, particularly the use of phenytoin. And this is despite a fairly recent policy position by the Royal College of Psychiatrists and active communications on this issue. And again, staff working in the community had the lowest levels of confidence on this. and evidence that both nurses and psychiatrists lack knowledge about e-cigarettes and how to utilize these as a effective quitting aid. Again, these are just a couple of quotes. The quotes I found are quite rich. And one mental health nurse pointed out that sometimes people confused the withdrawal from nicotine as something else, and that resulted in people getting increased medication that they don't particularly needed, and actually it was the nicotine withdrawal that should have been addressed. And the second quote is from a psychiatrist who just simply didn't know how to refer anyone to smoking cessation service, even if the person had indicated that they wanted to give up smoking, that the professional didn't know what to do with that, so they didn't know where to send them. Again, the recommendations are around improving knowledge and skills in current staff. So we would ask that NHS trusts train and deliver each part of very brief advice, so people know how to do the ask, advise and act. And again, both for inpatient and community settings, and include information about the local pathways. Also, trusts need to ensure that the training on medications is regularly updated, and ensure staff have the knowledge around e-cigarettes and stop smoking medications in order to confidently support patients to make positive choices that they often want to make. Going on to staff beliefs and attitudes, whilst the importance of smoking as a risk factor for poor health is widely appreciated among staff, there were certainly certain beliefs, and they were quite prominent, that were likely to cause or create barriers to addressing smoking. And these included beliefs that, for example, quitting may be detrimental to mental health, or smoking plays a positive role in the culture of mental health settings, policies are unethical, and addressing smoking is just simply not the role of mental health professionals. These aren't, I mean, these are findings that are found again and again in different research. I mean, this mirrors findings that were found in a systematic review and meta-analysis, which also found a significant proportion of mental health professionals held negative attitudes towards smoking cessation and permissive attitudes towards smoking. Staff understanding of the harms of smoking and the inequalities it drives appear detached from their understanding of the purpose of smoke-free policies. So people totally understand the harms of smoking and inequalities, but the health promotion and harm reduction intentions of smoke-free policies were rarely acknowledged when we were discussing them in the focus groups. And participants instead discussed the policies about the negative impacts, and used quite negative wording about banning and prohibition, rather than kind of health promotion and reductions in health inequalities. Again, some great quotes. So we know that training is required to dispel misconceptions and to address negative attitudes and beliefs. Training can also help build resilience by making staff less susceptible to influence of colleagues who hold such negative beliefs. And these are consistently found in literature and can be a major barrier to change. So while they can be addressed to some extent through training, they are also underpinned by organizational culture. So changes won't be achieved by training alone. Again, the recommendations are set out to address these issues, and it's important that people are aware that delivery of very brief advice can literally take 30 seconds. It won't take up much of their consultation time or time talking to a patient, and that really we need programs that seek to improve staff attitudes. For example, you could promote the use of reflective practice, including peer-led sessions, using mentorship to support reflection and learning, and also involve service users. It's really important that we involve service users and hear their stories about smoking and quitting, because these are true stories and they're really powerful.
1 minute, Lucy.
Thanks. I'll rush through this then. Organisational barriers. We found there was a lot of organisational barriers. There was a lack of consistent support across pathways, and training can improve organisational barriers, but its impact is also limited by these inhibiting factors. it was found that there was kind of maybe a disconnect between inpatient and community services in about their support for people who were going into hospital or coming out having quit. I will skip through quickly these. It's just that recommendations really need to be tailored again for community and inpatient settings, and they reflect the organisation realities for professionals. Importantly, that leaders as well as frontline staff need to receive training relevant to their role, and how important it is that the whole trust is on board, from the chief exec right down to people on the front line. And they really need to enable a supportive culture. Lastly, we need to ensure that good practice is sustained over time. I'm echoing. Can everyone hear that? I think my microphone has gone a bit funny. Apologies for that. I'll conclude by saying this research shows that after 10 years of smoke-free legislation was implemented in mental health settings, improvements have been made in some areas, but the culture of smoking persists. And the implementation of evidence-based interventions is maybe poor in some trusts. Lack of knowledge and skills about the use of varenicline, the most effective licensed smoking cessation aid, really needs addressing. Some mental health professionals still lack the knowledge and skills and motivation and the mindset to address smoking, but largely down to lack of training and the environment they work in. It's not a blame game. It's saying that the system is failing professionals as well to help them deliver the support that is needed. We don't expect nurses to be professionals in behavioural change, but we would obviously expect people to know how to deliver very, very brief advice and refer people to the right support that they need. Lastly, I'll just say it's really encouraging that our research shows that there's a clear appetite across the survey and the focus groups for more training, and it's evident that professionals do understand the harm that smoking is doing to patients, and they do want to improve their patients' lives. John, shall I pass back to you?
Thanks, Lucy.
Andy, sorry.
That's okay. It's an incredibly important presentation. Thank you so much for sharing the research. The report, by the way, will be shared with everyone who's here. There will be an email go around at the end. I believe it's email. It may be something else, might be a carrier pigeon, I don't know, but you will get a copy of the report as well as all the slides and various other bits and bobs. I think a recording as well from this event. Now, a couple of technical things. First of all, some people have said, where's the questions? And the truth is, I can't see it. So there is a chat function. So if you don't have a questions tab, as Hazel has just put into the chat, then bung your questions in the chat, and that way we'll get them that way. If you don't have access to that either, use the email address that was given at the beginning, admin@smokefreeaction.org.uk, to send your questions. That way we'll definitely make sure that you have a chance to ask anything you want to ask of the speakers, and do so at any time. We will take all the questions at the end, but send them when you think of them, and that way we know we've got hold of them, and we'll put every question either in this session or afterwards to the speakers. Now, one of the most important things about Equally Well, as colleagues will know who are members already, if you're not members already, why aren't you with us? Come and join us. Do become part of Equally Well. Get in touch either through the chat or other means about joining. But one of the crucial things about it is that everything we do is co-produced with an equal partnership between clinical and personal expertise. I'm really delighted that a member of our Experts by Experience group, Hannah Moore, is going to be speaking in the next session with Gabby Hashem, who works for Rethink Mental Illness and who works alongside our Experts by Experience group on Equally Well. And Hannah and Gabby, over to you.
Hello. Thanks, Andy. Thank you. Yeah, I think this is going to follow on really well from a quote that really struck me from the last presentation, which was that we need to listen to service users' stories around quitting smoking and what smoking means to them. So Yeah, I'm really excited to be joined by Hannah today. I'm Gabby. I'm the Senior Project Officer at Rethink Mental Illness, and I support and facilitate our Expert by Experience group. And Hannah, I think I just heard you're there, aren't you?
Yes, I am here.
Yeah. Hi, Hannah. Okay, so we'll
Hello.
just kick off. So when did you start smoking, and how long did you smoke for? And, what did smoking mean to you?
I'll just give you a quick, brief overview of my mental health kind of history because I thought it kind of fits in. So I was first entered into the community system at the age of about 8 years old, and then I was treated in the community and I wasn't smoking, obviously at 8 years old, but then I was put into hospital about 3 days after my 14th birthday, and this is where I stayed for just under a year, and I did smoke then, and actually increased my smoking because everyone else was doing it. After that, I was in and out of child psychiatric hospitals, therapeutic communities, and children's homes, but also including an admission to an adult ward when I was 15 years old, which shouldn't have happened. When I turned 18, I was transferred to the adult team in the adult hospital. I was a revolving door patient for a long time, and I was becoming more and more unwell and a risk to myself. So I was admitted to a PQ. I was still managing to hurt myself. So in my 20s, I was transferred to a secure hospital where I stayed for nearly 5 years. Um, Basically, I've been well I got out 5 years ago, over 5 years ago now. It was 5 years in September, and I've only had a couple of really short, quick admissions where I've been given ECT and then kind of shipped back into the community and done really well. But all of these hospitals, I went into them as a smoker. So I started smoking quite a young age, so 12 years old. I was already quite unwell and used smoking almost as a relief from my mental pain and the suffering, and a distraction and a way of being a bit defiant, really. And if I'm honest, what every kid at 12, 14 does is wants to look cool, which I don't think it is cool, but that's what I thought at the time. I actually had my first cigarette when I went to the shop with my older sister, and I guess it was downhill from there. This time I was studying classical singing and was regularly entered into competitions where I spent years winning my categories, but all smoking did was make my voice weaker, and it showed in where I placed because opera takes a lot of breath control, and when you're smoking probably about 5 or more a day at least, when I started, it was enough to not have the breath control I needed anymore. When I first got admitted to a child hospital, like I said, I just turned 14. When I was there, I was shocked to see that all the kids on the ward smoked, even the 12-year-olds, which, yeah. And then there was even a little garden within the ward that was used as a smoking area. This is where my smoking increased considerably. I went from about 5, maybe a few more than 5 a day, and my smoking increased to about 20 a day. And this was the case at like 12, 14 years old, sorry, I was smoking 20 a day. And this was the same in all my other placements.
Mm. So what prompted you to try quitting, and how successful were you in the end, and what was kind of your quitting journey?
Okay, so when my local trust became completely smoke free, it was a kick in the face because personally I know, and I know others did too, use smoke as a coping mechanism. And throughout all of the non-smoking hospitals I went through, even my SKU unit, I was never offered a personalised smoking cessation plan that was tailored to my needs. All I was ever given was the little inhalators until my last admission when I was actually asked if I was a smoker, and that I wouldn't be able to get leave as I was on section 3. So they offered me patches and gum, inhalators and spray, but it wasn't monitored at all. It was just the patches and no follow up at all. There's definitely a need for mental health staff to receive better smoking cessation training in order to better support service users. So I decided to go for the patches and the inhalators, but of course if I could sneak a cigarette, I was, and I have to admit, I was one of those annoying patients that would set the smoking alarm off while smoking in the toilet. So yes, I shouldn't have done that, but I did, and I'm proud of it. No, I'm not really. But when I went back into the community, I started smoking again, even though I'd spent nearly 5 years not smoking in a secure hospital. When I was there, I did try and stay quit, but I went into supported housing straight after I was discharged. in a week or two, I went back to smoking, which was I really regret, as I've smoked ever since. There was about 6 weeks, well, up until recently anyways, there was about 6 weeks where I used patches and tried to quit with my chemist at my local pharmacy, but then I started again. I also tried to go cold turkey, which didn't work. Then 5 months ago, I suddenly had the urge to quit. I don't know why, maybe because I wasn't enjoying it as much as I used to and the ridiculous amount of money that it was costing me. But I also did things differently this time and did it for myself, and not because my family wanted me to, and that's part of the reason why I think this worked this time. Also, I got help from a professional. So my first step was a consultation with a smoking nurse. We discussed what was available and we decided I would try the medication Champix. I don't know if anyone's heard of it, they probably have. I'm guessing everyone may have heard of it. So for the first 2 weeks of taking the medication, I continued to smoke, and I was supposed to smoke, make you go off smoking. I was really skeptical, but honestly, it's the best thing I've ever done. It really worked, and by the end of the 2 weeks, I'd gone from 20 cigarettes a day to about 3 or 4. One thing that I thought was really great and something that I had never properly had in the past was that I was assigned a specific non-smoking nurse at my doctor's surgery, who spoke to me weekly at first and then twice weekly. She was also available if you had any questions and you could ring the surgery. The only problem is the medication comes with some nasty side effects in relation to my mental health. For the first few months or so, I was fine. As I continued to take it, I was getting more and more depressed, and I was having horrendous nightmares, which were really horrible. But I wanted to continue, even though the nurse had expressed the concern. I agreed to half the dose, but things didn't improve, so I had to stop it eventually, as my mental health team were concerned. But although it did affect my mental health for a short period of time, I was pleased that I tried Champix, and it's the only thing that's really helped. I can officially say that I've been smoke-free for under 5 months now, and I truly believe it's one of the best things I've done, and I'm so pleased I don't smoke for many reasons. One being I have much more money. Smoking a day, that's like £330 a month. I don't have that money to spend on cigarettes. My singing voice is getting better. I've got a better range and can hit notes that I've not been able to hit for a long time. My family and my partner always have been really anti-smoking and regularly told me I stink. And yes, it was the smoke and not me, as they don't tell me I stink anymore. Now I don't smell of smoke. I don't miss things like, say I'm out with friends or at home with friends. I would go out for a cigarette and I'd come back and I would have missed half the conversation. So.
No, thank you for sharing your journey. I know it was been lots of stops and starts of you quitting smoking, but I'm really glad that, yeah, you've managed to keep this up now for 5 months. So, yeah, well done. That's amazing. Thank you so much for speaking honestly about your journey. I think just before we finish, I just wanted to ask you, kind of in your with your personal experience and your opinion, do you have any thoughts on what difference it would make to smokers if staff had more skills and knowledge about how to address tobacco dependence among their patients?
Yeah, so as I mentioned before, I didn't have much help with quitting until recently, but what I did get this time was really helpful, and I still have the support even though I'm nearly 5 months quit. So yes, I really think it would make such a difference to patients if staff were trained properly, especially when patients are in hospital, as going into hospital is hard without quitting smoking as well. But there are some things that I think staff could do to help patients who have had to quit because of coming into hospital, even if it's just for a short period of time until they're discharged. And having read some information, some of my points are popular within the smoking cessation. No one can 100% say if someone is going to be in hospital a week or if they could be there for years. When I went in, I never thought I would be there for 5 years, but I was. So back in the community soon. I started will start. Oh, I've lost where I am. It's not pointless, and the more you say and do to help them, the more likely they say quit. So yeah.
Yeah,
You
so
need to,
don't assume people will be there necessarily for a short time and that it's pointless and there's no point. Just always give people support, even if you think they're not going to be there for very long. Is that what you're?
Yes, that is exactly what I was trying to say,
I
but
thought
couldn't
so.
So I've got a couple more points. I'll be quick though. You need to constantly tell your patients they are doing well, and that quitting is hard, and that they're doing it. Tell them that all the benefits, and this will make them much more likely to stay quit. Once they're in a community and have a choice about smoking, if you have ingrained it into them, all the benefits, including money, that's what keeps me going, knowing how much I'm saving every day. They will be much more likely to say quit. Also, number two, I don't think that, oh, they have mental health conditions, so we can't use shock tactics. Of course you can. The dangers of smoking don't stop because you have a mental illness. Patients should be taught about the risks and that they stink. Be the one to initiate the conversation regarding smoking with the patient is first admitted. I can remember one time I was in hospital, it wasn't until I saw another patient with one of the little inhalators that I knew we could even have them on the ward. Also give the patient options as to what kind of nicotine replacement therapy they would like, or if they had anything in mind. If they don't, then recommend one. And number five, it would be really helpful if you had a designated smoking nurse or support worker who was available for patients to talk to. Another one is maybe have patients' key workers embed it into patients' care plans and make it something that would be talked about regularly. Also, when someone hits a milestone, this should be celebrated or at least acknowledged. If I was an inpatient again and I still smoked, let's hope both things, they don't ever happen. But this is the kind of thing that I would want done. I think that's all. Yeah.
No, thank you, Hannah. Thank you so much. And those were really, really powerful and important points that I think mirror a lot of the recommendations that Ash have put in their report, unsurprisingly. So no, thanks, Hannah. And I think there'll be a chance to maybe talk to you and ask you some questions at the later at the end of the session.
I'm more than happy to answer questions.
Back to you, Andy.
Thank you so much, Hannah and Gabby. Just a profoundly important conversation that which I think touches on so many issues. We were lucky enough, Centre for Mental Health and Rethink, to carry out a piece of research that we published earlier this year. Some other things have happened this year, so you may not have seen it, but there is a report on our website on smoking and mental health with many more experiences and insights from people who have been there and walked the walk, and this has been their story. So please do have a look at that, and we will be glad to share it. If I can work out how to put things on the chat, I'll send you a link. Otherwise, we'll make sure it goes out with the notes of this conversation. Do keep questions coming in. If you've got the question bar on your screen, well, you're lucky. I haven't, but put it in there. If you haven't, put the questions in the chat. If you haven't got that, email them. We want your questions. It's terribly important. Otherwise, the last session will be rather silent. Now, one of the things we're also incredibly lucky to do as part of Equally Well is work with our wonderful friends at York University who have this most extraordinary program of work called Closing the Gap. Simon Gilbody is the lead for that program and the quite brilliant Scimitar trial. And I'm really pleased Simon is here to join us today to share the incredibly important results of that absolutely landmark piece of research. Simon, over to you.
So Andy, thank you for the very generous introduction, and particular thanks to Ash and to Equally Well for organising this brilliant seminar. And I just want to acknowledge the very powerful testimony that Hannah just gave us about her journey to smoke-free. I thought that was so exciting and so inspiring. So thank you, Hannah, for sharing that. So I'm Simon Gilbody, and I am based at the University of York, where together with my colleague, Dr. Emily Pecker, we led the Scimitar trial, the smoking cessation trial. And I've been asked to speak about Scimitar, but in particular thinking about how the lessons we take away from this trial help us think about how we might embed smoking cessation into mental health services. So it's with an eye to that, I'm going to move on to my next slide, which is just to give you an outline of what I'll speak to over the next 8 minutes or so. So Scimitar, it's a really exciting project, and we delivered this with some brilliant colleagues and collaborators. It really was a cast of thousands, and it is the largest trial of a behavioural intervention for people who smoke and use mental health services. So I'm going to tell you very briefly what this intervention looked like, and I'll say what we found, what the important take-home messages are. But I think the most important thing for today's discussion is what we think are the implications for mental health services and for tobacco control policy. So I'll try to work through those. So I've got a summary slide here, so you can zone out a little bit because these are the main things I'm going to say. So people with severe mental ill health have some of the highest rates of smoking of any section of our population. And when we ask people who use mental health services and are smokers, the majority of them actually want to quit or to cut down. But the tragedy is that most people aren't helped to access and have not historically benefited from what I'm going to call conventional stop smoking services. So it's in order to address that gap in uptake and service provision that we designed the Scimitar trial and the intervention that sits at the centre of the Scimitar trial. And in this trial, we test a specialist intervention designed specifically to meet the needs of people with severe mental ill health who are interested in quitting, and we want to help people who want to quit successfully. And the results show us that we can get really good engagement, and we've managed to establish that we get verified improvements in quit rates, both in the medium and in the long term. And I'll speak about those in a bit more detail. So we think that this is timely, evidence-supported, an evidence-supported model for service provision. So I'll think a bit about that. So Scimitar's a big study, and before we embarked on this very large study, we tried to build strong foundations for the design of the trial and the intervention that sits at the centre of this trial. So here I've got 3 interesting papers that are available freely in the public domain. You can see these if you want to dig down a bit further. So moving from left to right, first we did a systematic review to see what works, and it showed that the things that work for the rest of the population could potentially work for people with severe mental ill health. And we spent a lot of time working alongside people with lived experience of mental ill health to think about what it was that didn't work for them in conventional smoking cessation services and what we might need to do in order to tweak our intervention so that it was acceptable. So we spent some time doing some important qualitative research to design and evaluate our intervention. We call that Making the Journey With Me. So it's a really interesting paper in the public domain. And then the final one on the right is we did a mini-me trial first. So before we embarked on a big trial, we did a smaller trial just to check that we could get things right and could be confident that we can move forward to a full trial. So the Scimitar trial is an evaluation of a bespoke smoking cessation intervention for people who use mental health services. So I'll say a little bit about how that came about, and that might be useful for people who are thinking about what a smoking cessation service might look like in their place of work or the place where they receive care. So the first thing to say is that we didn't reinvent the wheel. For people who don't know, there are some brilliant resources in the public domain, and the best by a country mile are the resources that are produced by the National Centre for Smoking Cessation and Training, a partner organisation in this programme of research. And over a number of years, they've thought about what are the optimum way in which you deliver smoking cessation services for people in the NHS and in other settings. And they've come up with a really neat way of training people to deliver an evidence-supported programme. And they call this the standard treatment programme. So there's got great provenance in this intervention. So that was our starting point. But we recognised that there might be some additional things we might need to do to add to that standard treatment programme. So at the centre of our intervention was the notion that we should train people who work within mental health services to deliver this intervention. So we trained using the NCSCT training programmes up to what I'm going to call level 2, people who work within mental health services. So everyone who delivered this intervention was someone who had direct experience working within mental health services and a deep appreciation of the particular challenges faced by smokers who use mental health services. We train them to deliver some really easy to learn but very effective, what I'm going to call behaviour change techniques that sit at the centre of this intervention that help maximise engagement and success in quitting. And we offered some pharmacological support to minimise any withdrawal symptoms when people did try to quit smoking. So nicotine replacement, NRT, was the mainstay of treatment that was offered, but it was one of a number of different treatment options that were available to people. So people got the choice of what they wanted to use, and the most people went for nicotine replacement therapy. And the other thing we found was that people were often unconfident about making a quit attempt. So we gave them an option of using what we call nicotine preloading to first cut down to quit, to see if by using nicotine replacement therapy, it might reduce people's craving for cigarettes. And if you can see some early gains by reducing the number of cigarettes that you smoke in any one day, that might give you the confidence to set a quit date. So we gave people this option. Only a small proportion of people took us up on the option, but it was important that that was there in the ask and the offer. And we also offered advice on psychotropic medication management, because if you're a heavy smoker and you take psychotropic medications, if you quit, it gives you the opportunity and the need to cut down the dosages of medication that you use. And that's quite an attractive offer to people who take medication. The option of taking lower doses of medication is always attractive. And we spent some time planning a quit attempt, and we spent a lot of time working with people to think about what they might do to fill the cigarette-shaped hole in their lives. So often people have been heavy smokers for long periods of time, so trying to think about what to do during those times when you would normally have a cigarette and the context within which cigarette smoking happened. So we designed a manual, and supervision was offered to ensure that the intervention that was given within the Scimitar trial showed fidelity to this manual that was delivered. So my colleague Della Bailey offered really excellent supervision, so we can be confident that it was high quality therapy that was offered in the Scimitar trial. So this is what the trial looked like. There were people with severe mental ill health who were heavy smokers, and we recruited and randomly allocated over 500 participants who were heavy smokers and have been smoking for on average 30 years. So these were long histories of smoking, people who had long established smoking patterns of tobacco use. And half the people were offered the bespoke smoking cessation intervention, and the other half were signposted to what I'm going to call usual care. So that was whatever was the standard offer for people who use mental health services who wanted to quit smoking in the particular context in which we recruited them. And usually that was referral back to your GP or an invitation to attend local non-specialist stop smoking services. And the way in which we tested whether this was effective was we got people to expire into a carbon monoxide measuring machine, both at 6 months and at 12 months. And that way we could establish beyond a shadow of a doubt whether people have been smoking recently in the past few days. So, and we look for sustained quitting, 7-day reported abstinence at 6 and 12 months. We looked at a range of other outcomes to check what happened. So here's the take-home message, what we found. So if you receive this bespoke smoking cessation intervention, it doubled your chances of successfully quitting. So that's a really important clinical outcome that shows that this is successful, and it's much more successful than standard smoking cessation services. People engaged really well. So the effort that we put in designing and tweaking this intervention really paid off. So on average, people engaged for about 6 sessions, and over 80% of people who were made this offer engaged with the intervention, and they told us they liked the intervention. If I were able to give a longer talk, like Lucy, I would pull up some quotes. So people really liked the fact that it was delivered within mental health services. They liked the fact that the person who helped them make the quit journey was someone who had a deep appreciation of the particular challenges faced by people who use mental health services. And the other thing is that in the usual care arm, pretty much nobody engaged with standard smoking cessation services. So making the offer that might involve going speaking to your GP, making an appointment, or trying to make contact with standard non-mental health specialist quit smoking services, very few people actually followed through and made those appointments and then made a successful quit attempt. So there's a graph that shows the difference in our quit rates. I'm not going to dwell on those too much, but since we published the results of this trial, we've been working really hard with lots and lots of partners. So we published in Lancet Psychiatry a couple of years ago. We're really proud to be working with ASH and with the National Centre for Smoking Cessation and Training. And this was funded by a large funder for research and development. We're in the NHS, and that's the National Institute for Health Research. So here are the take-home messages. So I'll just spend the last couple of minutes going over these. We think that the implications for training of these. It highlights the ability and the advantage of people from within mental health services rather than outside of mental health services receiving training to deliver this intervention. And the positive feedback we receive from people who use services really amplified that message. I've spoken about not reinventing the wheel. The NCSCT, the National Centre for Smoking Cessation Training, is a brilliant resource. So if you've not visited their website, take a look at the resources, the videos, the training materials and the courses that are on offer there, because we think that this should form the backbone of all smoking cessation training programs and the enhancements of skills in the National Health Services. If you were to think about delivering a smoking cessation intervention, try and keep it simple. Try and reduce the number of moving parts within any system to help people quit smoking. So don't send people off to see their GP to get their prescriptions. Try and make sure this happens as a one-stop shop that is delivered alongside the care that people receive within mental health services. And we think it's really important that this happens within mental health services rather than farming this service out to standard smoking cessation services. And one of the challenges we faced within the trial was trying to make sure that people got the medications to support their quit attempt. So it's really important that there's a one-stop shop for this as well. So don't send people off to their GPs to ask for nicotine replacement therapy. Try and make sure that that happens within the service so that they don't have to make additional appointments to have that. So what would we recommend for training? So I think this amplifies the points that come out from the ASH report. Lucy made this point really well, so I want to amplify that. Try and make every contact count. Every time there's an encounter between someone who uses services and someone who works within services, you should use that as an opportunity to help people think about their health, and if people are smokers, then ask, advise and act. And there are really good ways in which you can learn those key skills. And again, take a look at the resources on the NCSCT website, because there's a really neat brief training package around very brief advice. And we think that should be a core skill of everyone who works in NHS mental health services. So that's for everyone. The level of training we offered in the trial we think is suitable for some staff, but not all staff. So people from within mental health services, a smaller number of specifically identified members of staff, can be trained up to these level 2 levels of competency, and they can deliver with some additional skills the sort of intervention that we've evaluated in the Scimitar trial. We think it's really important that there are no barriers at all to the prescribing of effective quit smoking medication. So, and this might involve people who are non-medically qualified making recommendations for treatment. And my psychiatrist colleagues, I heard the messages that Lucy heard from psychiatrists in the focus groups that she organised, and it didn't surprise me. We think psychiatrists should be very conversant with the way in which you can help optimise the use of smoking cessation medications and the implications for quitting in terms of the dosage requirements for psychotropic medications that people might receive. It's important that you cut down the dose in a planned manner if someone successfully quits, and we think that's a core skill. So I'll finish there. I've got a note that I always have to put up from our fund. This was funded by the NIHR Health Technology Assessment Programme. So thank you everyone for listening. Thank you to Andy for organising and keeping us to time. So I've stopped speaking now.
I don't know if I'm doing well keeping people to time, but Simon, thank you so much for a fascinating presentation. It's a superb piece of work, Scimitar, and it's really helped us set the agenda for all of us who are campaigning around this to really make it clear that this is possible. It can and should be done, and I think we almost need to see a kind of rights-based approach to support to quit smoking when people want to, and everything we've heard so far today really kind of reinforces that view. We're getting some wonderful questions through, so that's brilliant. Thank you for sending those. If you haven't had a chance to ask a question yet, even if we don't get to it in this session, we will definitely get to it afterwards. I say we, it's not me, because it's my lovely colleagues at ASH who will be answering the questions. So that's nice and easy for me. Right, I'm now hopeful, and hope is very important. It sometimes feels like all we have, but we should have Kath Gamble from the Royal College of Nursing, who has chaired for a while now the Mental Health Forum of the RCN and been an incredible ally for equal physical health for people living with a mental illness alongside colleagues there. So Kath is working with new technology today. So I'm hoping you're here and in a minute I'll be able to hear you. Are you there, Kath?
I hope I am.
You are. Wonderful. Over to you.
To describe to you what a relief it is that you can hear me. I'm sorry you can't see me, but yes, behind the scenes, NHS compatibility with this network is not necessarily, but I'm delighted to be here. As you say, I've been the programme director for the RCN mental health programme. And I have just stepped down as the professional lead for the RCN, and I've done some great work with you, Andy, and with Equally Well UK. So this is a real privilege to be able to I'm delighted to be around to consider that this report really identifying the gaps that we have highlighted through our Parative Esteem programme, which was led by Tim Coupland, who is a member and sits on the Equally Well UK group with you and others representing the RCN. We wanted to really recognise that, as the report says, that we see sort of smoking for patients as inevitable, and we really want to challenge that and be part of the agenda that says that really too many professionals wrongly believe that their patients don't want to quit. Well, I've had the privilege as a practicing mental health nurse, I've had the amazing privilege to work with a lot of people who don't want to fit into that stereotype, and they wish to live much healthier lives. In fact, in 2013, I was able to write up a case study in which we did my area of expertise lies in working with families, and we worked with a family to support. And what it proved a fantastic opportunity to actually not talk about psychosis. This was a young man who actually had never said that he'd experienced any form of hallucination, but we went in and talked all about smoking. And in fact, therapeutic use of self, I used some of my own experiences of stopping smoking and how I'd actually had to write a letter and to say goodbye to the smoking Catherine Gamble, and the new healthier one was coming. So one of the things that I was able to do in that case study and to talk to this young man about was the different things, and to say what we were also letting go of as well as what we were saying goodbye or hello to in terms of a healthier life. And what that actually demonstrated to me that was actually a different way of engaging with this young man. And through about a week, we did a couple of weeks, we did around how he would be supported by his family to stop, how he would work with us, and what things he needed to look out for side effects of his medication and things that he might see happening to him. And one of the biggest points for me was that I came away really liberated by talking about a physical health issue, which then ultimately 3 or 4 sessions in, this young man started to talk about the gating theory and how he thought that perhaps actually it had come to him that maybe he was smoking to actually combat his voices. And the colleague that I worked with, Robert Joseph, and I at South West London in St George's nearly fell off our perches, because he'd never actually admitted to ever having any voice hearing experiences. And because we were using this in a non-critical environment and we weren't talking about psychosis, it gave him an opportunity to really just find his own time to talk to us about those principles. And we know from that there's huge myths and misconceptions about that people don't want to make these lifestyles. So this report is really highlighting what we really need to do. I think the other point is that there's many mental health nurses now, and some of my academic colleagues who are looking and helping and supporting this campaign. But we do know that training is only the tip of the iceberg. And we do know it is a change in culture, as you've highlighted. It's about stigma. It's about dressing our own attitudes and beliefs about whether patients are able to stop and how able they are to take these on. But as everybody is suggesting, there are lots of ways in which we can have that conversation and to start it and to keep repeating it and to offer more available. And we have a big smoking cessation programme at South West London in St George's, where I work. One of the things that we have done in 2017, a Congress resolution for the RCN, our members, and in the report that subsequently came out in 2019, our members said that they needed more action to address the current mortality gap and for serious mental illness, and they recognised the importance of being appropriately trained and being proficient in physical health assessments and knowing what to do after making those assessments and how to refer them on. So to this end, the parity of esteem work that we are campaigning for and doing at the moment seeks ways to collaboratively address the problems that people with serious mental ill health face. So our report actually highlighted ways for nurses to address that mortality gap, and as we've already talked about, working with Equally Well UK. We provided in that report some really good practical examples and some practical tips. So I do hope that we'll be able to provide that link and how nurses can influence this important issue. One of the things that we reflected on was that nurses should be able to expect a number of key things that they could help with this particular campaign. Was that workplace activities should be really around aimed at raising awareness and knowledge and skills, and that we should campaigning for better provision of post-registration training and good supervision in practice. And for the people themselves is having opportunities to access the smoking cessation services, and also the community staff and their psychiatrists to be much more informed and aware of ways in which to help people to address the no smoking issue particularly. And also we've called for the fact that environments need to be better equipped to meet the physical health needs of our client group, for example, clinic spaces and the appropriate equipment, and making sort of reasonable adjustments to ensuring that people get the right checks at the right time. And as I said, incorporating the social networks, because often we can be unwittingly, families and people can say all sorts of detrimental things. But as we heard earlier from Hannah, that she said, you know, how appreciative her family were when she did stop smoking, because she smelt nicer. She was obviously more communicative and more able to share in activities, because she wasn't necessarily running away to have a cigarette. So 6 things we were asked in our report to do was that we would suggest that local services need to be integrated for some of services for those with serious mental illnesses. We're asking nurses to ask and identify what their services are doing to train and support the physical and or mental health needs for patients. And we're campaigning to ensure that we're doing more about specialist roles, and more through advanced nurse practitioners, but also through the development of more nurses, and now mental health nurses are working in acute care and vice versa. So we think there's much more opportunity to learn together. And that's what we're doing with the rotation programme at South West London and St George's with St George's. We've also encouraging people to consider and ask what evidence-based tools are being used to measure and help improve the social, improve the physical health outcomes, and also ultimately asking what we can do around developing mental health promotion roles, and asking the so what question. So knowing that someone has completed a physical health check is only the first step, and we recognise that we need to consider what interventions may be required and what information someone may need, and what future community-based services could help people improve their health. So we're right behind you. We're delighted that this report has identified that we all need training, and we need that supervision. So thank you very much for inviting me to be part of this.
Thank you so much, and it's incredibly powerful and important to have your support, and I think also thank you for drawing on your own lived experience. Sometimes it's really difficult for professionals to acknowledge that this is something that is often personal as well, and lots of people who use services tell us they really value it when professionals are enabled to acknowledge that they're human too. So thank you for bringing a human as well as organisational perspective to this. Okay, we've got a wee bit of time for your questions, and I've just got two that I'm going to ask because we are near the end of our time. If you have any further questions, you can still put them on the chat or anywhere else, and they will be answered afterwards. But Simon, I had a really critical question, which I think is really probably you're the best person to answer if you can, which is what should people on this call do if they or colleagues or people they work with are concerned about anti-smoking medications, either about their effectiveness or safety for people with a mental illness? What would your advice be to respond to those concerns?
So, I mean, the first thing that we should always think about with respect to the sort of safety of anti-smoking medications is just how bad for people's health smoking is. So, and we can be confident over numbers of years of research and numbers of hundreds of studies that show that we can effectively help people to quit smoking. And there are ways in which we can maximise the chances of quitting smoking. Part of that is receiving the kind of effective behavioural interventions that I've spoke to. But we know that those interventions are always more effective if they are supplemented with some pharmacological support to help people to quit smoking. And I've talked about some of the benefits of quitting smoking for people who use mental health services. And one of the immediate benefits is your dosage requirement for psychotropic medications generally goes down. So just think about some of the positives as well. And there is some extensive research that talks about the safety profile of various different medications, and there are a range of different medications. So not all medications will be right for someone. So nicotine replacement is what we used in the Scimitar trial by and large, and we know that nicotine replacement is very, very safe, so safe that you can buy it over the counter, and it just replaces the nicotine that you would otherwise be receiving through cigarettes, but it means that you don't receive all the toxic compounds that sit alongside nicotine in cigarettes. So people keep smoking because of nicotine dependence, but they become very unwell and their life is foreshortened because of all the toxic things that are in tobacco compounds in cigarettes. So that's a really important message. So the medications are safe, and there's always going to be a safe medication that's right for you. It's important that you speak to someone who has experience of the various pros and cons of different medications. So, so those are the main arguments I've advanced.
Thanks, Simon. It's incredibly important that we keep hearing this message and keep sharing it, and hopefully colleagues on this call will be the next set of people who will go and share that with the people they're working with, and thank you. I'm going to ask Hannah and Gabby a question in a minute, and I'm hoping you'll either be on microphone or on visual, or both if you wish. And most of the comments a number of comments we've had have been, first of all, to thank Hannah for sharing your experience and doing so in a way which is really compelling and tells such an important story, but also important reflections. And really for Hannah and Gabby, really, I guess the question that we're hearing is, how can people that haven't been part of this webinar hear some of the stories and lived experience? Are there resources available online, or how within a local area can people go about understanding what this means to people living with a mental illness, and what would you recommend about ways in which people can hear this experience who haven't had the good fortune to be part of this today?
I think there needs to be training, some proper training within mental health impatience, because most of my experience is impatience with smoking, and there needs to be like a proper robust training, staff to be trained in non-smoking, in doing smoking cessation, being that one-to-one support with people. And I just think that, I don't know, I'm not really sure how we would get it out there. I guess share, Royal College of Psychiatrists could share things, Twitter. I'm not really sure really, but I just think there needs to be training.
I think they're great suggestions. I think just speak to people, listen to people, give service users the chance to have a dialogue and tell you their needs and tell you what they want. Try and approach local charities or voluntary organisations in your area. People who work on the ground. It might be that they want to do more work on smoking cessation, but maybe don't have the time or the money. I would also recommend the report that we wrote earlier in the year, Andy, that I think you already recommended, that Rethink Mental Illness wrote with the Centre for Mental Health, called A Time to Quit, and we spoke to lots of different service users for that piece. We did like a survey, and we also did like qualitative interviews as well, and that's like full of like really rich quotes and direct experiences, kind of just like Hannah's. So I'd really recommend reading that. But yeah, I think just speak to people about what
Word
they want.
of mouth as well, I guess. Yeah, like I think I'll be bringing it up in the numerous groups that I'm involved in, with either the Royal College or I was going to say Equally Well then, but we are here, and other things that I'm involved in. I will definitely be starting to, because I want to advocate for it, because it's such a good thing, quitting smoking. I've always never wanted to quit. Everyone's like, "You're going to quit?" It's like, no, I enjoy it. So, and you know, and I'm so glad I've quit now.
Thanks, Hannah, and thanks, Gabby, as well. And all those resources are available online, and hopefully, if our colleagues Ash won't mind, we'll share some of the stuff we've done in the messages that go out after this. We didn't get around to answering all the questions, but we have that undertaking to do so separately, so you'll get any responses to questions, and we'll share them with everyone so that people can see. So there will be a recording of this event, so you can watch it again if you enjoyed it, and if not, you can share it with any colleagues who would like to see it. I think with that, there'll also be an evaluation form. Normally you do evaluation forms at the end of an event when you go to it physically, don't you? So please do fill those in. They'll be incredibly useful to the organisers to learn from what you thought about it. Please do get involved with the work of the Mental Health and Smoking Partnership. It's a fantastic coalition. We're really privileged to be a part of it, and Ash do an amazing job in organising that and making it one of their big priorities. And I'm really lucky. I feel very lucky to work with Ash on this. And if your organisation is involved in Equally Well already, that's fantastic. Make this part of your Equally Well pledge. If for some reason your organisation hasn't joined, please go and nag someone and tell them to get involved. Being part of Equally Well UK is brilliant. And yes, I would say that, wouldn't I? But you get access to some really good stuff. And thank you. You are kind.
I really feel listened to. I feel listened to. Sorry, I'm butting in. I shouldn't butt in.
No, that's fine. That proves you feel listened to, doesn't it? So the value of co-production is such that it's absolutely the heart of what we do, and we're incredibly privileged to have Hannah and other members of the group at the absolute heart of Equally Well. And as Gabby said, you can do that locally too. It doesn't have to be something that only happens in one place. It can happen in every single place. I would like to particularly thank Hazel and John for organising today's event. It's been quite complex. We've had some ups and downs with the technology, but they did a fantastic job of getting everyone together, and I'm so grateful we've been able to have this conversation. Finally, I just want to remind you of something that Hannah said earlier, which I noted down because it's incredibly important as a parting thought. The dangers of smoking don't stop just because you have a mental illness. And some of the myths and the rather old school ideas that have circulated around this issue, it's time to put them to bed for once and for all and give people the support they should really have had a right to all along. Thanks for joining us. Have a good afternoon, and hopefully everyone on this call will get to have a bit of a Christmas break soon, and take care and stay well, and thank you.